great kickoff. Next, we're going to have Elsie Ross. We're so excited Elsie could join us today. Elsie is a vascular surgeon at the University of California, San Diego, trained at Stanford and learned a lot about artificial intelligence and machine learning there, and has really been a leader in sort of thinking about how to apply it to vascular disease and particularly PAD. Elsie is first going to give us a talk about her thoughts about how machine learning can improve risk prediction in PAD, and then we're going to have a panel up here talking about how to put it into practice. So, Elsie.
Thank you, Dr. Conti, Isabel, Molly, everyone who put this together and also gave me the opportunity to give my thoughts about AI and its relation to vascular disease. I have no disclosures for this talk, but that is not to say that if you're not in pharma or industry, you can't fund this work. I would look forward to it. As Isabel says, there's not enough money to do a lot of this. So Isabel and I talked a while ago about what I should talk about, and then I changed it, mostly because I thought, Vascular Cures is an organization, very forward-thinking, and so it seemed like an audience where we can sort of, again, look at the 30,000-foot view of what we should be doing with AI in vascular disease management in general. And the way I like to think about how I choose projects and how I want to see AI applied to vascular disease care is through comprehensive vascular care. But before we can talk about what AI should do in comprehensive vascular care, we should figure out what, or at least set some parameters of how I define comprehensive vascular care. So these days, if you want to ask a question, you go to ChatGPT, but prior to 2020, you might have went to Twitter to figure out what is comprehensive vascular care, and there's a lot of information. Joe Mills is a very prolific tweeter, and to him, comprehensive vascular care means multidisciplinary care, so having a lot of different physicians weighing in on a patient and how they should be treated to improve some outcome. It's also thinking about comprehensive care in terms of the surgical management of the patient, not being too focused on endovascular techniques primarily, but being able to apply open surgery to a vascular problem. It's also outreach and education, right? Like improving, especially in underserved areas of the country, trying to improve education. It could be innovation, developing new models of care, developing new technologies, and then bringing that back to the bedside for the patient. And for some people, it's self-care, like making sure that you're rested and engaging in good activities so you can be ready for the challenge of taking care of these really sick patients. I like to think of it a bit more simply in terms of a framework of who, what, and how. Like who's involved in comprehensive care, what kinds of things should be done, and how do we do them? So there's a lot of people involved in the detection of vascular disease and the management, right? So there's primary care, there's cardiologists, vascular specialists, a surgeon like myself, but also other health professionals like podiatrists, physical therapy, nutrition that can improve the outcome of our vascular patients. Then there's the what. I spend a lot of time thinking about early detection. Can early detection help us better manage our patients? Risk factor management, trying to keep PAD patients from having another heart attack or losing their limbs. There's surgical care for our symptomatic patients and our CLTI patients. And then there's postoperative surveillance is also something that is part of comprehensive care. And more wound care is adding to the comprehensive care model. Then the how. How do we enable all this what that we want to do? There's technology, obviously. I play in the space of artificial intelligence. There's more technologies being developed for remote monitoring and clinical pathways for that. There's also policy. Policy can enable comprehensive care if there's new legislation that, usually not a carrot, it's usually a stick to penalize us for not giving high quality care. And then there's the financial incentive, right? Like insurance companies could incentivize us to provide better comprehensive care. This is a lot, and I'm not going to cover it in 20 minutes, so I'm going to focus on the things that I have experience in, which is artificial intelligence and its application to early detection, risk factor management, and surveillance. Oh yeah, it works now. It didn't work before. So what are my objectives? So the things I want you to take away from this talk is to understand the labor required to translate AI research to clinical implementation for vascular care, but to also start to identify areas of AI application for comprehensive vascular care. I have a few examples, but there are likely many, many others where we can think about this. So detection is where I've spent most of my career so far, because I truly believe that there's a lot of misdiagnosed PAD. Either patients are deemed asymptomatic, but they actually have symptoms that are typical, and if we actually capture these patients, we could put them on medication sooner and impact their long-term health. And I'll give the overview, which is I was a postdoc after my PGY3 year working with a vascular medicine specialist that said, we don't identify PAD enough, and these patients unfortunately then go on to limb loss and heart attacks and all this other stuff. So I, being a computer literate person, said, I'm going to spend some time figuring out what this machine learning stuff is, and is it useful for a use case that's important, identifying PAD. It turns out that compared to regular statistical models, that machine learning actually had a lot to provide in terms of being able to better classify patients and predict future mortality. So fast forward to when I'm on faculty, and the question moves on from can machine learning do this to can we use machine learning in a way that actually informs care? And at the time, I had spent a lot of time working on electronic health record data, and so I figured if we built models in the electronic health record, we can then give the information to clinicians and have them do something about this alerts or understanding patients who are high risk. And then thankfully, around 2023, 2024, Stanford Healthcare had developed its data science team, which was tasked with actually implementing AI. So it became not which types of data to use, but if we do something different, and eventually will patients with PAD to live healthier lives. So a lot of work that was done in partnership with Dr. Fukaya and Abhi Pandya for the panel to share their experiences with the actual implementation pitfalls and things to consider. So I could have spent a lot of time the technical details of these models, but I feel like there's a shift, right? Like we're no longer thinking whether techniques can be used for cases, and it's more about like we have machine learning and AI, and how do we implement it? So the what here is earlier detection of PAD. The how is a physicianal alert about a risk for PAD would improve outcomes or change practice. But if you take a step back, you have to think, does EHR implementation of alerts actually work? So taking away AI altogether. If I give a clinician an alert that they should do something based on best evidence, will they do it if it's presented in the EHR? So this study was done at Yale. It was a question, and they asked the question, do EHR alerts improve 90-day lipid-lowering therapy intensification? And this should be a slam dunk, right? Like we all know that if you give, if someone's on a statin or a similar drug and their LDL is not less than 70 or not less than 55 by some guidelines, their lipid management needs to be intensified. And all you're doing is alerting the clinician of this. So you would think that this would be an easy win. So this was a single institution cluster randomized study. So what does cluster randomization mean? So for those who haven't heard of this term before, so in a regular randomized study, you randomize patients to treatment, but there's gonna be some circumstances where you don't wanna randomize the patient because if a provider sees one patient that gets an alert and then another patient that doesn't get the alert, there's gonna be contamination of effects. So you randomize by cluster, which is by the provider. So the provider's panel of patients is randomized to alert. Another provider's panel of patients is randomized to no alert. So they included internal medicine and cardiology patients, and the treatment arm was an alert that was sent to the provider for lipid intensification recommendations for patients at high risk of major cardiovascular events. In the control arm, those patients and providers didn't get an alert, and they were just, usual care. And the outcome was, is there a change in their lipid intensification at 90 days? And then they had some secondary outcomes looking at lipid levels. So what happened? So they got 47 clinicians whose patients did not get an alert, and 49, so almost 100 physicians whose patients did get an alert, and they saw no statistical difference in 90-day lipid intensification or the secondary outcomes at all. Kind of depressing. So if you see here, and it might be hard to see in the back, but essentially in the patients who did get the alert, in the arm where they did get the alert, there was a numerically higher intensification of lipids, but it wasn't statistically different than in the no alert group. So as someone who's about to develop a trial to then add in this AI piece that people may not trust, the question then becomes, maybe EHR alerts aren't the way to go. And I'll talk about the Stanford model and how it's different from this and how we have to think about these implementation choices. So if you look in the details, you'll learn that for 52% of patients in this study, the clinician just deferred the alert. They just clicked off. They weren't interested. 20% gave an excuse like it's not medically indicated for some reason. But the majority of the time when they deferred the alert, it was because they were not the primary provider for that patient. It was not their job to intensify their lipids. So again, this is an important thing to consider when you're trying to change behavior in healthcare, like who's getting the alert when, and are they empowered to act on it? Because if you look at the patients who did not get the deferral, the provider actually engaged with the alert, there was a twofold increase in odds of them having their lipids intensified. So again, it does show that EHR alerts can work. It just depends on like who's engaging in it and why. There was another study similarly at Yale that was actually done earlier, and this was looking at heart failure. Again, not AI related, but again, the goal here is to engage with the EHR and engage a certain group of people to do something about care. So in this study, they looked at do targeted and tailored EHR alerts improve guideline medical therapy in use of patients with reduced heart failure for reduced EF. Single institution, same thing, cluster randomized, looked at internal medicine and cardiologists. Treatment arm, you got an alert for a recommend, and this alert was different. You got alerted that this patient has heart failure, there's 4 classes of medications, and this patient isn't on 2 of them, and here are recommendations for medications you should put them on. The control arm, again, didn't get an alert, and the primary outcome was like, what's the proportion of patients with an increase in the number of prescribed guideline medical therapies, and then they had a lot of other secondary measures. So these results were positive. I mean, small but positive, that if you gave clinicians this alert, they actually added medications. But when you looked at the medication they added, it was beta blockers. But they didn't feel comfortable changing the ACE or SGLT1 inhibitors, et cetera. So it's interesting what people are comfortable with doing when you do alert them of needed changes here. I'll skip ahead. And to say that this does have impact downstream. And they found that direct hospitalizations were lower in the patient groups where they did get an alert and there was an action. The difference here, too, was that they actually engaged the clinicians a lot before they put this alert out. There were a lot of focus groups on what should this alert look like, how do you want it to appear, when do you want it to appear in the record? Is it as soon as you open the patient's chart, or is it when you're putting in orders? And so a lot of clinicians felt that this alert was helpful, and 90% actually engaged in the alert rather than dismissing it. And I think in medicine and AI, and especially for vascular disease and AI, we're at a critical point. So everyone's excited about AI when it comes out, right? There's a lot of public funding, the NIH, DOD, et cetera. Everyone's pouring in money, and you're taking it from the basic technology, like I showed when I was a postdoc, from can it even do this, to the point that it can do this, and we need to now see what the use cases are that are actually going to give us enough evidence and data to take this forward. And that's when, you know, it's either private funding or something else that helps you disseminate this further. But between then, it's this valley of death. And I think if we don't smartly implement these technologies and then evaluate them more rigorously, then we're going to end up, again, as mentioned by Dr. Patel, with a bunch of models that never went anywhere, and it'll be the end of it. And I think for diseases like vascular diseases that aren't as sexy as heart failure or cardiovascular risk management. It's even more dangerous if you have a lot of trials that fail to show an impact of AI and X, because there's just not enough money to keep trying, but we do need to, and so we need to be smarter about the implementation. And some ways to do this is to engage with implementation scientists. I'm not an implementation scientist, but I'm lucky to be in an organization that has a great implementation science group, and to start thinking not only about the frameworks, but also to plan and design these implementation strategies, but also how to evaluate them in a way that's going to be clinically useful. So for instance, this website was developed by implementation scientists at UCSD, at University of Colorado and University of Washington in St. Louis, and is really a great intro into these frameworks, and you can really spend a lot of hours here doing a deep dive when you're trying to figure out how to translate AI into clinical care. And then there are institutional examples. We heard of what they do at Duke. At Stanford, they developed a similar model. So if you're a researcher or a vendor saying, I want to implement AI into your healthcare system, it has to go through an evaluation to figure out if this is a fair, useful, and reliable AI model. And that has many considerations. Is this financially viable for a hospital to implement, or is this going to bankrupt the system? What are the ethics of it? What happens when you start identifying all these PAD patients? Are other physicians or surgeons not going to operate on them now because they think they're too high risk? So you have to think through a lot of things as you implement these models. And at UCSD, our chief transformation officer, our head of AI implementation, and implementation scientists believe that we should actually start creating centers where we can evaluate the clinical effectiveness and have a network of centers, again, similar to what Duke does, to test these models for clinical effectiveness. So what did we end up designing at Stanford? So very different than the prompt studies, where the prompts don't necessarily go to a clinician. First, there's a model, and it fires off these many patients are at high risk of having PAD. And you'll see as I go through these slides, the model is a very small piece of this whole clinical implementation. Once the model makes a prediction, there's patients who are above a certain threshold of risk. And so it's actually a vascular medicine specialty patient flow coordinator or a medical assistant who checks the list for sanity. Like, does this make sense that this patient might be at high risk of having PAD? And then we actually go to the PCP and say, are you willing to make a referral to vascular medicine? So sending it to someone who wants to own the process of taking this care and not putting the onus necessarily on the primary care physician who may or may not have a lot of experience with diagnosing and managing PAD. If the PCP says yes, then there's a referral. Then the patient gets put into a different workflow. The patient also has to agree. There's a lot of ways that people can kind of fall out of this pipeline, but the patient has to agree to come see a vascular medicine for their vascular medicine visit, and then we incorporate the APP. So not necessarily, not everything needs a physician to screen and evaluate the disease process. You can also empower other healthcare providers. And then once they get their ABI and testing, if it's positive versus negative, there are different parts of the workflow that the patient go into. So then that brings into question, I sadly left Stanford a year ago, but still keep in good touch with everyone there, but I want to bring this to UCSD. And it's going to be very different for several reasons. One is that the patient population is just different. Oops, my clicker's no longer working. Yeah, different. And the other thing is that, like, I'm starting to talk to the primary care providers, and they just have different sets of goals. They have their own population health team, and so there are a lot of different other considerations. So some considerations to think about as we try to implement AI is, do the MDs need to receive an alert if that's how the pathway that we're going to go down? Are the right people getting the alert at the right time? Can we empower others on the team, as I've mentioned? Like team-based models, there's a lot more traction of having pharmacy-led initiatives to escalate and de-escalate medications, for instance. And is the action easy and low risk, making it more likely someone will act on it? And what about referrals to specialists, like in the Stanford example, where you give the information to people who are really going to take it forward and feel comfortable managing that disease process? And should we or can we use these AI in general to expand services? So if we're suddenly going to start increasing the number of patients that we detect with PAD, maybe we should be using outlying centers where we're looking for growth in our clinical programs rather than everyone coming to the main hospital, again, maybe I, for instance. And then is an alert even the right action? Like maybe we can think even higher scale about this and look at it at a population level. And so that's where I get into disease management, right? So I finally identify all these patients with PAD, but how many people here know how many patients are in their health system that have PAD? How many people know how many of them are on guideline recommended therapy? How many people know the percentage at risk of losing their limb in 1 year? There's so much we do not know about our patients because as a clinician, I'm seeing them one at a time. But can we start to think more broadly about how we manage this population? Because the PAD patient it has a long road ahead of them to getting qualified, excellent care. And we can clearly use AI to help with that, but then how do we look at it more broadly? And one way to think about it is through registries. So Dr. Aruda Olson, who's at the Mayo Clinic, put out a paper describing their use of a digital registry to help with secondary prevention of PAD. So this was more analog and manual process, but can you hyperspeed, like move this to hyperspeed and allow AI to help you automate a lot of the processes? So the other great thing about UCSD is it loves dashboards and registries. And so this is a dashboard every physician gets nearly every day about COVID readiness. I don't care too much about COVID readiness now, but you can imagine using this for PAD and understanding all the factors that are important to understand about your PAD patient. And so we're starting to build a registry and dashboards to help us understand what's going on with our PAD patients. Now you add AI to the mix and you can start automating important things like identification of who are your high-risk patients and who you need to reach out to. There's also the field of individualized treatment effects. So if you have a randomized controlled trial, on average, patients should benefit from the medication or the device for the FDA to approve it. But in that bell curve, there's also the tails of the curve, right? There are people who are going to get outsized benefit and people who are going to be harmed. And you can use machine learning techniques or even statistical techniques to identify who in your population will benefit most from a drug or a device and who might actually be harmed and need to be de-escalated. And then in my initial schematic of the who, what, and how, there was the patient at the center. I haven't mentioned it much, but with large language models, as we've talked about, there are examples of how you can use it to engage patients. And then surveillance is the last thing I'll end with quickly in trying to think about the comprehensive care model. So vascular surveillance, many of us know this well, but there are over 200,000 patients who get procedures like endovascular procedures per year, and the guidelines are to surveil these people. And if you think about that, every year we're adding more and more patients to the surveillance pipeline. How are we really keeping up? And a lot of these patients are lost to follow-up. We know that things can happen within the interval that even if a patient is getting their regular follow-up, their stents can go down, their bypass can go down, et cetera. And rural patients, and I'll say even inner city patients that don't have good access to public transportation can be disadvantaged by not having access to vascular centers. So is there a way to develop technology that allows us to monitor these bypasses and interventions at home? So ask your friendly nanotechnologist. And so we're working with a nanotechnology lab who integrates AI into their devices. And they've built a patch that can just go on. It can go on a carotid, it can go on the neck, it can go on the leg, to try to pick up waveforms like Doppler waveforms, ultrasound waveforms, just through the skin, and the AI is in the software that renders the image. So they're able to track the vessel through the skin and through movement. And so we've just completed preliminary analysis of how good this patch is in healthy volunteers, looking at the carotids, looking at the common femoral and SFA. And we found, like, if you compare it to like a state-of-the-art ultrasound machine and probe, the patch actually gives you pretty good information. And so now you can start thinking about having this patch go home with patients or using it in the hospital. But mostly, I like to think of it as a way for patients who are underserved, who can't come back all the time, to kind of help monitor their disease going forward. So, in conclusion, comprehensive vascular care and AI is coming into view. I can see it being the next paradigm for how we take care of our patients. There are many opportunities to improve care along the patient journey. I think the harder work will actually be in the implementation. And this is coming from a person that like codes models, and I'll just pick up whatever algorithm of the day or du jour there is, and I can apply it to something, and I'll find something, but like, how is this actually going to get implemented to improve patient care? And implementation science, clinical effectiveness networks can help us cross the valley of death. Thank you. Yeah. No, they were not. Again,
So
these, yeah.
would empowering patients to receive, I don't know if this is on, to receive the alert, would that improve implementation? Some patients will follow up better than
Yes, yes.
absent-minded doctor.
Yeah, so similar to alerts with guideline recommendations versus AI, or alerts that go to the provider, there has been some research on alerts that go to patients about diseases that have nothing to do with AI, and the evidence is mixed. Like you said, some patients will act on that information and some won't, and so again, it's an area that needs more research. So organizations like PCORI that are very much into patient-centered outcomes would be great to start to evaluate how patients want to see AI, how they want it used for their data.
Thanks very much. My name is Bobby Chang from San Francisco. I'm just curious whether you've had to justify to your health system the sort of proven benefits of identifying patients who are presumably asymptomatic at the time. Because about 10 years ago, we tried to screen for PAD in Kaiser. We basically, just sort of back of the envelope picked high-risk features like a history of coronary disease, diabetes over a certain age. And we came up with 6,000 or 7,000 patients in Northern California, and we started this pilot program. We basically ABI'd everyone until we got to a certain point where we were producing results, and we're like, okay, what are we going to do now? And so the answer was, well, we're going to have a clinic, we're going to have a vascular medicine thing, we're going to put everybody on, cardiovascular risk reduction. And then the leadership stepped in because they started to look at cost, and they said, okay, we like the fact that you're identifying ICD-9 codes or 10 codes, and patients are being tagged with an additional PAD diagnosis, which, as you all know, helps with the Medicare reimbursement aspect every year. It's like an annuity. That's great. But in terms of like, well, what is, the question they asked was, what is the proven benefit of treating someone with an asymptomatic disease that you're actually going to improve outcomes? And at the time, we had no data. And so basically, the program got quashed because of that. They didn't want to spend, like 10 FTEs or more on a virtual clinic. And then, the potential harm of treating patients with no known outcome results.
Right.
So I'm just curious as to like how you're navigating that issue, or if you haven't gotten to
Yeah,
that.
that'll be great to ask Dr. Fukai and Abby during the panel on how Stanford thinks of it. I think it was right place, right time for the implementation. So Stanford Data Science Office and the AI Initiative were starting, and they were looking around for models, and they were like, this could be good. And they evaluated the PAD use case and found that it could be at least, if not like profit-driven, but also wouldn't financially put the hospital at harm, and could break even or even see increases in utilization of healthcare because PAD patients have other things, namely heart disease, that need to be taken care of. So at least on the face of it, it seemed like a reasonable thing to pursue. which is great because my whole goal is to see if identifying these patients earlier will end up changing outcomes. So that's where I'm trying to get to. There have been some studies in Denmark saying that screening for things like AAA, hypertension, and then they add in things like ABI screening, et cetera, can change medical management and patient outcomes. There were 2 trials. One was positive, one was sort of neutral except for stroke prevention. So there's limited data in certain populations that show that there might be benefit. So the point of all this at the end of the day is to generate evidence to see if this works. The other thing I think AI can be helpful for is reducing the number of FTEs needed to run a virtual clinic, right? If we're automating a large part of this process, we can use key people at different parts of the decision and care process so that you're not having to use a larger team and you can kind of pare that down.